Hello, this is Dr. Nabih Mukhtar, Senior Clinical Fellow Critical Care Medicine UK, and in this presentation we are going to talk about sedation in ICU. Sedation is frequently needed in ICU, but prior to make a decision of starting sedation, you need to make sure that you understand what is the actual problem of the patient, and if the patient is actually in need for a sedation, or he might be in need for something else like anesthesia, anxiolysis, and now let's start to talk about various types of sedative medications which we can use in ICU. The first group of medications we are going to talk about is the benzodiazepines. And benzodiazepines are particularly effective for relieving anxiety and producing amnesia and hypnosis, but all can produce some degree of cardiovascular and respiratory depressions. So the range of available benzodiazepines includes relatively old drugs like diazepam, and much more commonly used medication in ICU is the midazolam. And also one of the other most commonly used medication is the lorazepam, especially for delirium. We are going to talk about each one separately. Let's start talking about midazolam, which is one of the benzodiazepines commonly used in ICU with a normal elimination half-life of 2 hours. But bear in mind that these might increase up to 24 hours in critically ill patients, and it has a high risk of accumulation, especially with patients of kidney failure or liver failure. And the usual bolus dose of midazolam is 2 to 5 milligram, and when used as a continuous intravenous infusion, the usual dose is from 2 to 10 milligram per hour. Lorazepam is one of the other benzodiazepine medications commonly used in ICU. It can be used to terminate seizure episodes, or can be used as well for hyperactive delirium and agitation in ICU. It can be given intravenous or intramuscular. If given intravenous, the onset of action will be 1 to 3 minutes, but if given intramuscular, the onset of action will be 15 to 30 minutes. It can be given as well orally, with onset of action more later. The drug has a half-life of approximately 14 hours, and you need to know as well that lorazepam is should to be given as intravenous boluses, and it is not preferred to be given in a continuous infusion. For the dose of the lorazepam, we can find that if given for status epilepticus, it can be given as a bolus dose with a range from 2 to 4 milligram, and this can be repeated in 5 to 10 minutes. But if given for agitation in ICU, so we have an IV loading dose which will be from 0.02 to 0.04 milligram per kilogram, with maximum dose in a single dose not more than 2 milligram. And this can be used as well in maintenance interrupted doses from 0.02 to 0.06 milligram per kilogram every 2 to 6 hours as needed. And then diazepam, which is not currently used as much as before in the ICU, but still can be used as an alternative to lorazepam to terminate a seizure episode with an intravenous bolus dose from 2 to 5 milligram. And now let's talk about one of the most common sedatives used in ICU, which is the propofol. It is basically an anesthetic agent used for induction and maintenance of general anesthesia, and widely used, as I said, in ICU for intubated patients on mechanical ventilation. Propofol effects start quickly and end quickly, metabolized mostly by the liver. And one of the most important information you need to know about propofol is that it has a cardiorespiratory depressant effect and may produce significant hypotension, especially for hypovolemic patients and septic patients. Propofol can come in either 1% or 2% ampoules. This means that each ml either contains 10 mg of propofol if it is 1% or 20 mg of propofol if it is 2%. The drug is usually given by continuous infusion, and the usual dose is starting from 0.3 mg per kilogram per hour, and the maximum dose is 4 mg per kilogram per hour. Propofol syndrome is a rare syndrome associated with prolonged propofol infusion and can lead to some complications like rhabdomyolysis, heart failure, developing metabolic acidosis, and renal failure. So in these patients you can find high serum triglycerides, high serum CK, high potassium level, and liver enlargement. And bear in mind that patients who are receiving steroids are at high risk of developing propofol syndrome, and treatment is basically supportive. You need to stop giving propofol and it changes the sedation protocol to another sedative. Ketamine is not commonly used for sedation in ICU, but it is an anesthetic agent which can be used for induction and maintaining anesthesia. It has an advantage is that it is normally stimulates rather than depress the cardiorespiratory system. So it is normally increases the heart rate and arterial blood pressure in normal patients, but bear in mind that these might not occur in critically ill patients. Also, you need to know that ketamine increases the cerebral blood flow and metabolism, and this means that it might raise the intracranial pressure. So you need to take this into your account if you are dealing with a patient suspected to have a high intracranial pressure in neuro ICU. One of the great advantages of the ketamine is that it is a good bronchodilator, so you can use ketamine for induction if you need to intubate a patient with a status asthmaticus. And the major adverse effect of the ketamine is developing nightmares and hallucination. So always use a low dose of benzodiazepine with the ketamine to stop these adverse effects. Thiopentone is one of the other sedatives which is rarely used in ICU, but it can be considered for patients receiving mechanical ventilation who are difficult to be sedated with any other agents. It can be used as well as a second-line therapy for refractory intracranial hypertension, and it is one of the most important uses of thiopentone. Also, thiopentone is an extreme effective anticonvulsant agent. So it can be used for refractory seizure as an IV bolus of 25 mg. Thiopentone is a short-acting sedative. However, clearance is by hepatic metabolism, and when given in a prolonged infusion, thiopentone will accumulate, and this results in a prolonged recovery, particularly in patients with impaired liver function. So also you need to know that an IV bolus of thiopentone might cause significant hypotension. That's why the infusion is preferred for sedation, and the usual dose for the infusion is 2 to 5 mg per kilogram per hour, with a careful monitoring and reduction of the dose with time. Dexmedetomidine is actually one of the new sedatives used in ICU. It is a selective alpha-2 agonist that can be caused for light and moderate sedation, but is not recommended for deep sedation. One of its advantages is that it can relieve agitation and promote analgesia without significant respiratory depression. So that's why dexmedetomidine can be used for non-intubated patient. It is used as IV continuous infusion with a dose of 0.2, and the maximum is 1.4 microgram per kilogram per hour. And the evidence said that it can decrease the incidence of delirium and duration of mechanical ventilation as well. However, the disadvantages of dexmedetomidine include bradycardia, hypotension, and the cost. It is actually expensive, which makes limitation of use in ICU because it is very expensive. Clonidine is another alpha-2 agonist, but dexmedetomidine is more selective on the alpha-2 receptors. So compared to clonidine, dexmedetomidine is 8 times more potent. Thank you, and hope you enjoyed this presentation, and meet you in the next one.